Welcome to another episode of Cutting Edge Health. If we haven't met, I'm Dr. Orlando Landrum, and today we're talking about treating fibromyalgia and using transcranial magnetic stimulation and why it's different, and more importantly, why it can be better. If we haven't really talked about fibromyalgia recently, it's something that we really need to kind of go into. It's a condition that affects patients consistently and is not being managed as good as it could be. I've seen patients even as recently as today that are not managed even pharmacologically well. Most patients are moved off to the side and said, hey, you know, this is a problem, but you got to figure it out. We're going to treat some other things first and we'll come back to it. We're going to talk about fibromyalgia, what it entails, how it impacts people's lives, and different ways to be able to treat it. So as you guys know, we always look at papers first in order to be able to kind of see what's the background and the research behind it. So the papers that we're going to use today are a few. The first two are going to be looking at fibromyalgia and that aspect of what causes it, how you diagnose it and how you treat it. And then fibromyalgia, what are some of the recent diagnoses over the last 2 to 3 years or so? So what's the textbook definition of fibromyalgia? Well, originally it was believed to be this fibrosis because this was stressor that took place secondary to peripheral inflammation. But really what we believe is that it's a sensitization that takes place in the nerves. And where we think that sensitization occurs is something that's called the central sensitivity. So what is central sensitivity? What it means is there's nerves that's present in our periphery, but those nerves then relate to our spinal cord and then from there into the brain. And those areas have a response that we don't want to have that then results in a number of different things that we experience. And those are going to be things like feeling joint stiffness, chronic pain at these multiple tender points that we've talked about before, changes potentially even into how cognitively we are able to deal with things, sleep disturbances, anxiety, fatigue, and depressive episodes that we're going to go into a little bit of conversation about. So when most people assess this, they really want to try to get an idea about, so how does fibromyalgia get evaluated? So there's different tests, but at the end of the day, one of the things that they look at is how much of an impact does this cause on someone? Does it cause you problems with being able to function? Is it life disturbing? Does it cause you to be tired? Does it cause you to have pain? What is that type of pain? Is it present throughout? Do you have depression? Do you have headaches? Do you have joint pain that's present throughout? And then they grade it. And so those gradients look like the following. So on a 0 to 3 scale, do you have problems with the fatigue? Do you have problems waking up unrefreshed? Do you have problems with cognitive symptoms? And do you have problems with somatic symptoms? Cognitive being symptoms of you having depression, anxiety, and somatic being those joint pains and other things that we reference. So going back to that point, most people have this stigma that's associated with fibromyalgia and it always being secondary to something that's in your head, which isn't true. However, fibromyalgia does have a connection to depressive disorders. And most patients that have fibromyalgia officially diagnosed have depression that's present in about 40 to 80%. And most people are like, well, yeah, is that causing the fibromyalgia? No, it's because you hurt and you can't do the things that you want to do. who wouldn't be depressed in that context, right? And so when we look at those points that are present, this is kind of the classic diagram that you see. So you see these areas that are present within the neck, the lower back, the knees, the thighs, and such. And then if you go into a detailed look, this is what you see throughout: the occiput, the lower cervical, the trapezius muscles, the supraspinatus, the ribs, the areas in and around the glutes, the components of the hips, the knees. Those are the points that we talk about when we look at potentially feeling that sensation. Again, the thought process is currently that it's secondary to a connection with the nerves. So normally we talk about treating this and we use different types of medications, but we think about things like Lyrica and Cymbalta, which has traditionally been used for nerve pain. However, what if we could look at this a little bit differently? So using fancy language for a second, one of the things they talk about is this central sensitization, and they use this in medical terms that talk about it impacts perception, transmission, and how we see nociceptive stimuli. So what the heck does that mean in like regular English? What it basically means is that we're talking about how the nerves process a sensation that shouldn't be considered pain, but it makes us feel pain. And most people are like, you know what? I don't even want to deal with this. I just want to go back to what I was dealing with before and being normal, if you would. But that description has impact on not just the nerves alone, but it impacts the inflammatory system, the immune system, the endocrine system, and there's just a number of things that cause these pain sensations. So when we look at this broader, we look at the aspect of how the brain relates to the spinal cord. So this picture that you can see at the bottom lower left are those different points. Those points then are able to be relay the pain through peripheral nerves, which go into the spinal cord, which is that gray structure that's there that has a little slice. And you see something that's called a dorsal root ganglion that's present. And then it connects to the brain. And we have this sensitization that takes place with how we perceive pain and how descending fibers have inhibition of what that pain is like, which isn't as present. So inhibition, meaning we're stopping that pain stimulus. So that's where TMS differentiates itself. And we're going to talk about transcranial magnetic stimulation, its utilization, and what the studies have shown. But let's kind of focus on fibromyalgia and traditional treatments for just a little bit longer. So traditionally, we've thought about it as being a muscular disease, it being peripheral, and it having issues that are present. What some of the current thought processes now is that it's central nervous system mediated, and there's neurotransmitters that are different than what they normally would be. On top of that, how the brain communicates to itself, as well as to the spinal cord, is that connectivity may be changed and not optimized, and there's different ways to be able to make that better. In addition, there's been thoughts about, is it a small fiber neuropathy, which there's ways to be able to test for this using something that's called a punch biopsy. And sometimes you can see it and sometimes you can't. So we haven't been able to differentiate that it's definitively a small fiber issue. But this is the traditional algorithm for treating fibromyalgia. And if you can see this, great. If not, I'll kind of read it to you. But basically, you see the person, you can evaluate them, and you consider sending them with physical therapy, which most patients are like, you know what, if I could do physical therapy, I would have done it already. But when you put me in that, it really kind of causes more pain than not. The premise is that you're trying to desensitize those peripheral nerves, which is very difficult to do for most patients, but it's apt for some. But historically, the cost-effective margin that most insurances will choose is to try to send someone to physical therapy for this type of problem. Then when that invariably doesn't work, then they'll say, okay, we need to individually try and see if we can tailor therapy. So depending on what the major issue happens to be, whether it's sleep and pain, they'll consider using medications like I made mention of before, duloxetine and pregabalin, otherwise known as Cymbalta and Lyrica, and then consider adding in different medications to try and see if they can improve that. If they think that there's other mental elements that are present, like depression, anxiety, which would be normal, they'll talk about doing cognitive behavioral therapy or different medications that are associated with depression and anxiety. And then if there's other dysfunctions, then maybe they'll consider doing this multimodal rehab. Well, tell you what about if we do it differently? What if we consider doing it better? And that's one of the papers that looked at this. The effects of repetitive transcranial magnetic stimulation in fibromyalgia. So let's get down to the nitty gritty as opposed to going through all the full deal. Does it work or doesn't it? Well, when we look at the studies, this is what we see. So we know that it's better than the use of just a placebo, right? But then there's sometimes where you do this and it doesn't work at all. And there's sometimes where it works way better. So what is it? What's the difference? Well, this is what they found at the study. What they found, highlighted here, is that when you do TMS and you apply it over the M1 section of the brain, which I'm going to tell you about in just a second, versus you applying it on a dorsolateral prefrontal cortex, major difference. Major difference. A significant reduction in pain intensity using that application over the M1. So the question is what the heck is the M1 and what the heck is the dorsolateral prefrontal cortex? If you follow our channel, what you will know is dorsolateral prefrontal cortex really looks at the site specifically for mood and depression. Well, the M1 targets those areas that are the somatosensory areas, those areas that are the motor strip, those areas that are involved with actual nerves that apply directly to those pain stimuli. So if you place TMS at that site, you get a response. If you place it at the area that tries to trigger just mood alone, not so much. So another paper kind of basically summed it up as the following, is that TMS applied to the M1 region, you can see a reduction in pain for both the short and medium term. And you can do that with TMS and sometimes even TDCS, which we've talked about before. But if you try to do it at the dorsolateral prefrontal cortex, you might get some improvement in fatigue, but you're not going to necessarily get that improvement in pain. At the end of the day, it's a treatment option that doesn't have the same sequelae as what you do with pharmacologic management, meaning you got to take it every day. And on top of all that, you have the side effects that's associated with it. So if we can do something not just different, but potentially better, why don't we? And that would be the challenge that I would say is something for people to consider. And if you're interested in potentially being a patient for something of this ilk, then take a look at what our site does, what our channel does, and maybe we might be the entity that can be able to help you out. Hopefully this gives you an option to know how to be able to punch pain in the face and get back to leading your life that you deserve. Whether it's physical or mental limitations, you certainly can find a way to be able to do the things that you want to be able to do. Thank you so much and have a great day.